Hello, everyone, and welcome to the Philly Factor. Well, in these tough economic times, there are concerns that things such as health care, dental care, and even a trip to the eye doctor may suffer as people forego visits to the doctor's office for routine checkups. And that has many doctors, medical professionals concerned because putting off that trip to the doctor, whether it's to your primary care physician, maybe even to the dentist or the eye doctor, may have severe consequences down the road, especially when it comes to diseases and ailments that often go undetected. Recently, the More Eye Institute and the More Eye Foundation did its part to make sure that people get the eye care that they need in these tough economic times. They conducted a series of eye screenings, especially targeting glaucoma. Here to discuss in depth what glaucoma is, who suffers from glaucoma, and how you can treat glaucoma is Dr. Nancy Crawford, Director of Anterior Services at the More Eye Institute. And Dr. Crawford, thanks for spending some time with us here on the Philly Factor.
Oh, thanks for inviting me. It's a pleasure to be here.
A lot of people will hear the term glaucoma and they'll think they understand or think they know what glaucoma is. Before we get into a discussion of glaucoma, I think you as a medical professional would agree with my opening statement that a lot of people, given the current economic times that we're experiencing, are sort of putting on the back burner that trip to the doctor's office, whether it's to the dentist, the primary care physician, or maybe even to the eye doctor, and that oftentimes has severe consequences down the road.
Most definitely. As a matter of fact, the screenings are a work in progress, and they started when I every Christmas time I go around to my referring doctors just to touch base with them, see how they're doing, see if we can serve them any better. And I was getting a recurring theme this year that routine eye exams are down significantly when compared to a year ago. And not only was that bad for business for my colleagues, but from a glaucoma standpoint, it was horrifying, since many cases of glaucoma are picked up during a routine eye examination. And it turned out that these people who are putting off eye exams are not necessarily people who have lost jobs and lost their insurance. They may still have insurance, but have decided not to spring for new eyeglasses, and so they've put off the eye exam. So, you know, it is people who have lost their jobs, people who have no insurance, but it also are people who are trying to conserve and have decided not to spring for those new glasses, so they're putting off their eye examination, not knowing that their doctor does more than just measure for eyeglasses. They do a lot more than that.
Well, many people will put off a trip to the family doctor, whether they're suffering from flu-like symptoms or they may have sprained an ankle, and they'll say, I'll just work through the pain. How often should a person get in to see the eye doctor? I know it's a general question because oftentimes you have the children in the classroom who are having difficulty seeing the board, and of course the pediatrician recommends that children get to the eye doctor more often than most. But typically speaking, how often should a person get in to see the eye doctor?
I deal mostly with adults, so I'll speak for adults.
Sure, okay.
Adults should have a baseline eye examination at age 40, 2 years thereafter up to about age 60, and then yearly thereafter.
Okay. And would a person going into the ophthalmologist's office, if a person is 40, are they more suspect or prone to have glaucoma because 40 is the age that doctors start looking for some of these diseases of the eye?
There's a number of diseases that increase in incidence and prevalence with age. Cataracts are one, glaucoma is one, macular degeneration is one. And so at age 40, people are starting to need reading glasses, and that's a troublesome sign for them. But from a disease standpoint, that's a good time to get a baseline examination.
Okay. So let's discuss then what is glaucoma. As I said at the outset of the program, a lot of people hear the term. A lot of people say, no, I don't have a problem. You know, I have perfect 20/20 vision, not a problem for me. So what exactly is glaucoma? And would a person know that they have glaucoma if they don't go to the eye doctor?
That's an excellent question. Glaucoma is a group of diseases that causes damage to the optic nerve. And the optic nerve is a cable that consists of about 1 million nerve fibers that takes information from the eye to the brain. So basically, it's the big cable that allows your brain to see what the eye is, the information that the eye is gathering from the surrounding world. What was your other question?
The other question is, if I don't go to the eye doctor, would I know what the symptoms of glaucoma are? Would I know that I'm suffering from glaucoma if I don't go to the eye doctor?
No, glaucoma, by and large, the type of glaucoma we're talking about, primary open-angle glaucoma, has no symptoms in the early stages when it's most amenable to treatment. It's interesting that someone will call up our office because their eye is red from conjunctivitis, which is relatively a self-limited disease that will go on, take care of itself in a week.
Sure.
Yet glaucoma, which is one of the leading causes of blindness in the United States, has no symptoms. So it has no symptoms in the early stages. If you wait until you have a vision loss from glaucoma, you've lost 8 out of the 9 innings in your ball game.
So when you say vision loss, is it you're reading a book, on a Monday night, and you close the book and you wake up tomorrow morning and all of a sudden you pick up the same book and you can't make out the words on the page? I mean, people, because I think one thing that we take for granted is vision. It's like until you start to have a problem, do you realize that, oh my God, there's something going on here and I'm not quite sure what it is. So when you talk about vision loss, is it a significant loss of vision, or is it a gradual deterioration of vision that people may be aware of, or they're aware of it way too late in the game?
Studies have shown that you have to lose up to half of your nerve fibers before we can, even with our delicate testing, can pick up any signs of functional loss, any kind of loss of vision. Typically, glaucoma starts causing blind spots in your peripheral field of view, which often go unnoticed. Number one, because you're more concerned about your central vision, sure. And number two, because your eyes overlap one another. So if you're, for instance, experiencing a dark spot, let's say up here, you're not that bothered by it because one eye overlaps the other. Oftentimes these dark spots are attributed to other things. Oh, I think it's probably a cataract, I'll take care of it. Maybe I'll get my cataracts out next year.
Sure.
Or a floater, or all sorts of things. And unfortunately, if it's due to glaucoma, it's a permanent loss of field of view. Once there's a vision loss to glaucoma, we cannot restore it.
Wow. And that's pretty scary because, as I said, we take our vision for granted. The other thing is, I've heard people say that they have these field of vision tests, and that is that probably one of the tools, if not the standard, if you will, when people go for these field of vision tests that really determine if there has been any significant loss of vision because of glaucoma?
That's certainly one of the tests that we need to do to decide if someone has glaucoma. Okay. If you're talking about screening, a lot of screenings just check pressure, and that can be very deceptive. You can get a lot of false positives and false negatives because pressure is a contributing factor to many cases of glaucoma. And there's no question that as the pressure increases in the eye, the risk for glaucoma damage or damage to the optic nerve increases. But we know that pressure is not the whole story, because not everyone whose pressure goes up gets optic nerve damage. And some people whose pressures remain in the normal range can get optic nerve damage. Okay. So we know there's other factors. We know there might be genetic factors, it might be circulatory factors. There are other things that are involved. So.
Is glaucoma genetic? If my mother or father may have been diagnosed with glaucoma, am I likely to be a candidate? Or if I'm diagnosed with glaucoma, are my children likely to be candidates for glaucoma?
Most definitely. We mentioned high pressure as a risk factor, so that's one of the major risk factors. Age is another risk factor. We touched on that briefly, that with each passing decade, your risk of developing glaucoma increases. Family history is a big one. If you have a sibling or an immediate family member with that has been diagnosed with glaucoma, your risk increases up to 10-fold. So it's interesting you say that, because when we develop screening tests, we want to target people that are at the highest risk to make them, they're costly. So sure. You want to get the best bang for your buck. And one way to do that is to screen siblings of known cases of glaucoma. And we're going to be doing that later on in March, actually, have a sibling screening test.
Okay. I want to mention the phone number for the More Eye Institute as well as the website. So if people want more information about what More Eye Institute is doing and how you might even be able to participate in some of these screenings that we're talking about here, you can first of all call, if you like, 610-690-4900 extension 1256. You can get more information about those screenings that you talked about.
Correct.
And you could also go to moreeye.com. That's MOOREEYE.com and get more information about glaucoma and all the other great work that they do at the More Eye Institute. Is there a segment of the population, is there a demographic more prone, generally speaking, to glaucoma as opposed to other people that are in our society?
Most definitely. Glaucoma worldwide and in the United States is the second leading cause of blindness. But for African Americans, there's no question it is the #1 cause of blindness. African Americans, quite simply, get more glaucoma. They get it at a younger age. They typically have more severe disease at the time of diagnosis and are much more likely to go blind from the disease. So African Americans are particularly at risk, and that's one of the other 4 major risk factors, actually.
Are there other health issues that might contribute to the onset of glaucoma? For instance, sometimes when you do a family history, and if diabetes runs in the family, people that with diabetes, could worry about losing their eyesight if the diabetes isn't kept in check. I mean, are there other health issues and health factors that might contribute to glaucoma?
Diabetes it's interesting. We have always thought that diabetes increases the risk of glaucoma, and I still think so, although some of the clinical studies that have been sponsored by the NIH recently have had conflicting results. So the jury's out as far as that goes, but diabetics in general have such an increased risk of diabetic eye disease that they should have their eyes checked more frequently.
Sure, yeah. You mentioned pressure in a question that I just asked you, and you said high pressure is one of the ways that you diagnose glaucoma. So how do you get that pressure reading? And I know it's probably involves an instrument in or near the eye that sort of allows the doctor to sort of determine what that eye pressure is and whether that person is okay, borderline, for glaucoma, or in fact has glaucoma. So can we talk a little bit about how you get the pressure?
Okay. Well, first of all, there's a fluid in the front of the eye that's constantly flushing the front chamber of the eye. It's called aqueous humor, and in a normal eye, it's produced and drained at the same rate.
Okay.
With in certain people, for whatever reason, we know that the drain starts to get clogged. And since the eye is a closed system, it can't expand like a balloon. Instead, the pressure goes up, almost like overfilling a ball, like a soccer ball or something.
Okay.
And so the pressure goes up. The way we can, there are various ways in which we can measure pressure. There's an air puff that people might be familiar with, although that is probably less accurate. The most accurate means of measuring pressure involve touching the eye with an instrument.
Okay.
Sometimes it's in the form of a little pen. Sometimes at the slit lamp that people are probably familiar with in your eye doctor's office, where you put your chin here and put your forehead forward and touch a little prism to the surface of the eye. But we put a drop of local anesthetic in, and it takes a couple of seconds and is completely painless, so it's nothing to be afraid of. People don't like things approaching their eyes, but we manage to get good pressures.
Yeah. And what are good pressures then? I mean, if a doctor should turn around and say, oh, your numbers look good. And one thing I've always advocated is that whether you're going to the cardiologist, you're going to the primary care physician, if the doctor's telling you your numbers are bad or your numbers are good, you should always ask for those numbers. If they say, your blood pressure looks good, you should ask what the blood pressure numbers are. So what would be good pressures then for the eye?
Average range of pressures run from 11 to 21 millimeters of mercury.
Okay.
However, I mentioned previously that the pressure number alone is not a diagnosis of glaucoma. So you cannot just take a pressure and say you're okay. Your pressure is 16 and you're okay. Because some people, even with pressures in the normal range, still get glaucoma. So in order to diagnose glaucoma, you not only have to take the pressure, but you have to get a look at that optic nerve to see if there's any sign of damage, and you have to measure, do some sort of measurement of the person's peripheral field of view.
Okay. Now, how do you do that? What type of tests does a person have to go through to sort of get that accurate measure of the peripheral view, if you will? So this way, when the diagnosis is made, that definitively, you can tell that patient that this is what you're suffering from, and then begin a treatment program for them.
Well, there's something called computerized perimetry, where a patient sits with their head still, one eye is covered, they're asked to look straight ahead, and lights of varying intensity are shown from different directions, and the patient basically pushes a button when they see the light. And so that can detect if there's any areas where the patient isn't seeing well.
Okay. So now the diagnosis has been made, and the person is told they're suffering from glaucoma.
Or at least very suspicious.
Very suspicious, okay. So what happens then? I mean, do they just leave the office without any game plan? Are they told to stay away from bright lights, don't read as much, get a new pair of glasses? Or are they given eye drops, for instance, as a way to sort of treat? Because there is no cure for glaucoma. So do they walk away with a treatment option at that point?
That's also a great question. Sometimes you cannot make the diagnosis on one visit.
Okay.
The only way you can be sure that glaucoma exists is if there's progressive damage over time. So there's this whole gray area where someone might be considered a glaucoma suspect.
Okay.
For instance, they might have a high pressure reading but a normal appearing optic nerve. They might have a normal pressure reading at that point in time. Don't forget that when we do that measurement, that's one point in time, and most people have varying pressures throughout the day, like their blood pressure might vary. So they might have a normal pressure, yet a suspicious appearing optic nerve, and no blind spots. So those people, everything has to be individualized, but there's a certain category of patients where there might be a few red flags, but the story's not complete. It's not a definite diagnosis, and they have to be monitored periodically, anywhere from every 3 months to once a year.
How have the screenings been going at the Moore Eye Institute? Because it would seem that, especially when it comes to this type of eye care, where it's so specialized and it needs to be individualized, that as we get the word out about what is being done at Moore Eye Institute, that people are coming in for these screenings and at least coming away with a better understanding of just how important proper eye care really is.
I think the screenings have been terrific. By the end of Feb, we have 2 more screenings to go. We will have screened over 200 people.
Wow.
Out of that 200, some people come to screenings because they know they have glaucoma and they want a pressure check.
Sure.
But some people come because they've been told of high pressure or suspicion in the past and have not had the funds to have a full eye examination. And so they come for some reassurance that everything is okay. And I have to say, we do a very comprehensive screening. We not only do the pressure test, I take a look at the optic nerve, and if I'm suspicious for glaucoma, we actually do a computerized visual field test at that time.
So you can sort of, when a person comes in for the screening, or even if they're coming in for a regular visit, they're pretty much going to go through all of the test and the screening at that point. It's not like they're coming in and just having one portion of the screening done and then they have to come back a few weeks later. They're coming in and having everything done during that initial visit?
If I have a reasonable index of suspicion. If they come in and their pressure's 11 and their optic nerves look completely healthy, then we don't go ahead and do the visual field, because it takes about 10 minutes, and if you're trying to screen 50 people, that tends to be the bottleneck there. But if they have a lot of risk factors, such as African American heritage or a positive family history, and their pressure's a little bit elevated and their nerve looks a little suspicious, then we will do a visual field at that time.
How do you get to see the optic nerve? I mean, it's just fascinating because when I even go into my own eye doctor's office, he's got, you know, all these charts and things, and it's just fascinating because, you know, they can do all these great things with, you know, with catheters and cameras, and they could do arthroscopic surgery, and they could put these cameras and tubes and look inside your body and everything. But when it comes to the eye, you know, you only got two, and, you know, the thing is, you really can't see what's going on. I mean, the lay people can't see what's going on behind the eye, but you actually are able to peer, I guess it's through the pupil, to see what's going on behind the eye?
Yes. At the screenings, we don't normally dilate the pupil, so I can use an instrument called a direct ophthalmoscope and get a reasonable view of the optic nerve, providing there's nothing in my way, such as a significant cataract. That would impede my view. But I can get a pretty good view of the optic nerve. Now, it's always better to have your pupils dilated, and we do that during a comprehensive or a complete eye exam, because that allows a much wider field of view. So we can see a larger area of not only the optic nerve but the retina. So,
if a person comes in and you're starting to screen them for glaucoma and there is a cataract, do you, before you, I mean, how does that impede your ability to make, I guess, a concrete diagnosis? I mean, do you recommend that the person have the cataract removed first, or you sort of have an idea of what's going on while the cataract is still in the eye?
It makes it a little bit fuzzy. Looking through a cataract, looking out through a cataract is kind of like looking through a dirty window, and looking in is the same way. So I might have a hazier view of the optic nerve, but I can usually get a pretty good idea of whether there's significant damage.
The best way to treat then glaucoma, and I think we may have touched upon this a little while back, is that are you prescribing oral medication, or is it eye drops? You would think that, you know, eye drops, because you're dealing with the eye, and you know, you mentioned conjunctivitis. Many people, as you said, it'll take care of itself within a week, but most people will be clamoring to have some type of eye drop in order to help, you know, eliminate the pink eye, if you will. So what is the best, or, you know, what is the most accurate way to treat glaucoma? Since there isn't a cure, how do you treat it?
Well, that's an important point, and that is we discuss with each individual and make sure that they understand that this is a chronic disease that has no cure and that requires maintenance therapy. It's almost like a diabetic has to watch their diet and take their pills or their insulin, or someone with high blood pressure has to take their pills every day. There is no cure for glaucoma, and so it requires constant treatment, and we have to get their pressure down. Let me just say that right now, at this point in time, the only way we know how to treat glaucoma is to lower the pressure.
Okay.
So we use either drops, laser, or surgery to lower pressure.
Okay.
Oftentimes we start with drops first, but every treatment has its pros and its cons. There are a lot of good medications out on the market now where you can treat with 1 drop a day and get a reasonable 25 to 30% lowering in intraocular pressure. But they can be expensive, and oftentimes they're not covered by many people's insurances. So even people who think that they have sufficient insurance may find that their copay for the medication is prohibitive. Maybe it's $50 a month, and they're on 10 other medications, and they're spending a significant portion of their fixed income on medication. So drops are certainly one.
That's
sorry,
okay.
yeah,
There's somebody's cell phone going off in the studio. That's all right.
There's other reasons why drops may not be ideal, and that is people with arthritis, people with Alzheimer's who won't remember to do them, just a number of things.
Yeah. And you mentioned surgery too, which I didn't think that surgery might be an option for a glaucoma suspect. So surgery is
no. We usually reserve surgery until the end.
Okay.
Surgery until we've made a reasonable effort with 1 or 2, sometimes 3 drops, and or laser. And the reason I wanted to bring up laser is laser used to be not. We didn't consider that until we had exhausted all type of drop. Now we have a safer type of laser that works well, has minimal side effects, that is covered by insurance, and can lower the pressure 25 to 30%, just like one drop will. So some patients are opting to have laser as a first-line treatment.
Really?
Because then they don't have to worry about the drop. They don't have the monthly expense. They don't have to remember.
Where do you see treatment then going? I mean, we could look at it two ways. We could see, we could ask where the diagnosis is going to be going, and more, as more and more research comes down the road about glaucoma, you would hope that it's going to become easier to make the diagnosis. And then on the other end of that is the treatment option, and where, I mean, ultimately, where is this going to go in the next 5 or 10 years? Has it stayed pretty much the same for a while, or have there been strides been made even in the past few years?
Actually, there have been significant strides, and one is that when I was earlier in my training, let's say 15 to 20 years ago, we had this impression that lowering pressure was the correct thing to do.
Sure.
So the NIH has sponsored several clinical trials that have proven that lowering pressure helps glaucoma at all stages of the disease, whether it's early, middle, or late stage disease, whether it's male or female, whether it's African American or Caucasian. So we know that lowering pressure works for everyone at all stages of the disease. That was an important thing because we kind of there's a little guesswork involved. That's still the only definite way that we have to treat glaucoma is means of lowering pressure. Okay. In the forefront, we're looking at ways to maybe strengthen the optic nerve, strengthen the fibers so that they won't be so susceptible to elevations or fluctuations in intraocular pressure. Certainly, gene slicing might be an option down the road. So.
Well, there's a lot of great information that, of course, you can find out online at moreeye.com. Now, that is the website for the More Eye Institute, and that's MOOREEYE.com. And if you would like more information about the screenings that we're talking about, we encourage you to check the information out online, or you can also call the More Eye Institute. And again, here's that phone number. It's 610-690-4900, and you can get into one of those screenings. Just go to extension 1256. And someone there should be able to help you with one of those eye screenings, as the More Eye Institute sort of helps people who may, one way or another, for one reason or another, sort of let the eye care fall by the wayside right now because of these tough economic times. I want to thank Dr. Nancy Crawford, Director of Anterior Services at the More Eye Institute, for being with us on this edition of the program. Thanks so much for being with us.
Oh, thanks for asking me.
We covered a lot of territory, and hopefully we did a lot of good for people understanding what glaucoma is all about, and there might be a chance for you to get into one of those eye screenings. And we thank Dr. Crawford for being with us on this edition of the Philly Factor. Until the next time, thanks so much for being with us. I'm Paul Perello. Thanks for watching the Philly Factor.